next panel is moderated by Ms. Laura Landro, who may be the most widely read healthcare journalist in the country. For 35 years, she was an award-winning reporter and then editor at the Wall Street Journal, where she authored the Health Matters and Informed Patient columns, along with many special reports on healthcare innovation. She and her panel will be now talking to us about disruptive healthcare delivery models.
So I'm Laura Landro, and I'm very pleased to be here. This is a subject of great interest to me. Learning about all this effort going into digital technology and how technology can improve life for the aging as I begin to see myself doing so. And also having aging parents. In fact, my father is gone now, but my mom is in an assisted living facility, and I've had so much fun talking to everybody here about some of the great ideas that could help in those settings. I want to introduce first, do you go by doctor?
Joe.
Joe. Joe has written a book. I don't know if you guys have read it, but it's a book called, I want to make sure I get the right title. It's The Longevity Economy, and it's understanding unlocking the fastest growing, most misunderstood market. And one of the things that I learned in talking to him is something that I have personally experienced, which is often the adult daughter who is there making the decisions for these aging parents. And as the adult daughter with two brothers, the first thing I did with technology for my mom was I got a Nest camera. Now I feel a little bad about this because the Nest camera, she doesn't really know it's there, but I felt that it was an added measure of security, and I could make sure that she got up and went to lunch and dinner, and that the people that were coming in to care for her did what they were supposed to, and I let them know it was there. And every now and then there's a potato chip bag in front of it, or a candy in front of it, and maybe she does know it's there. But sure enough, when I sent the link to my brothers, they said, "Oh no, we're not spying on Mom, that's your thing." So anyway, that's my first foray into technology. But I wanted to get a sense, if you could share a little bit about what you have learned and how we can think about how we're going to use technology with people who are aging in place, aging in facilities, to kind of get the family involved and get the family doing the adult daughter and maybe the sons, if we can rope them in a little bit. What are the most important things that you've learned that we aren't understanding? How are we misunderstanding this market so badly?
Well, first off, thank you for being here. I want to thank Ray for putting this together over the years. This is a great event and a great agenda-setting event. Look, one of the reasons that we tend to misunderstand technology and aging is that we come to it with a very old mental model, not of the technology, but of the older adults. We have this notion that my mom, she doesn't like technology. My father, well, he just won't get it. Does anyone know what we call technology that your mom and dad don't get? Bad technology. It's not about them, ladies and gentlemen. If you're a designer, if you're a distributor, if you're in the medical area, you should not be worrying about whether the older adult gets it. It's whether you get what they need to understand in terms of not just usability. That's the base point. But do they mind the privacy trade-off? Does it provide something more than it's time for you to take your medication? We did work with Nippon Telephone and Telegraph a number of years ago that showed that we could actually increase medication adherence, not by telling people to take your meds or having something glow or beep or vibrate, the countless ways we do this, but rather, can we improve the communication between you and your grandchildren, you and someone else, and then slip in the message about medical? No, we are over-medicalizing old age, and as a result, first off, all the great ideas out there, the first thing we ask is, can it be reimbursed? Ladies and gentlemen, reimbursement is not innovation. Innovation is when you want to take the money out of your pocket or your mom's pocket because you want it, not because you need it. The other thing that we've learned as well, it's about services. Just because you've got a call center that says you haven't taken your meds today or that you've gained weight today, we need to start thinking about what are all the services that go around that. Who is the trusted number that you, the adult daughter or older adult, is going to call to aggregate, install, maintain, teach, and pull out when the stuff breaks or does not work? And then lastly, the one thing that we've learned, and this is, I'm looking at good friends like Sandra Markwood and others here, we need a smart buyer. There is no one place that adult daughter can go to say, this is the set of technologies I want, this is the architecture I can get put into the house. until we commercialize this, not for Blue Cross or United, not for CMS, but for the consumer, the most misunderstood market is you and I. Because frankly, we're looking for little devices to do task-based living, like taking your meds. It's about old age, it's about living, not medication, not body weight, and not blood pressure.
Well, we also have two MDs here who went on to found companies that are looking at some of these issues. One, how to care for people in nursing rooms when they have an emergency, nursing homes when they have an emergency, and another to keep them out of nursing homes if at all possible. And you know, if he fails, he takes over. But I think, Matt, you also mentioned that your view of technology has been a lot of solutions looking for problems. And this reimbursement issue, as you say, is still very important. No matter what you find that's groovy, you have to find a way to pay for it. So tell us a bit about your program, what your company is doing and taking advantage of this PACE program that's, I think, in 30 states now, and how does that work?
Sure. Also very, very grateful to be here. And I've had a relationship with West for over the years, not only with Wellbe, but with other companies too. So it's a pleasure to be part of the community and spend time with all of you. So Wellbe Health, we are a startup, and we are the first kind of startup program to do de novo PACE programs. PACE was mentioned a couple times today. So Program of All-Inclusive Care for the Elderly. For those of you who don't know it, it is the best kept secret in healthcare. It is the gold standard model of healthcare, in my opinion. So we are a fully integrated payer provider. PACE, the most simple way to describe PACE is that it's for anybody over the age of 55 who is nursing home eligible, who does not want to age in a nursing home. That's the simplest way to describe it. What PACE ends up being, a typical PACE participant, when it ends up being, is usually average age of 85 or so, Medicare and Medicaid, 6 or 7 comorbid chronic medical conditions, 50% with dementia. So these are the frailest of the frail, most vulnerable members of our society. And so we receive a fully capitated payment from Medicare and Medicaid, and we are at risk for 100% of their medical and social loss. So you may look at me and say, why on earth would you ever want to do that? Why would you want to take on that risk? And it really speaks to a lot of the things that were just mentioned. So the way that PACE succeeds is the interdisciplinary care team. So it is the integration of the care mechanism with the program. So it's the doctors, the nurses, social workers, physical therapists, occupational therapists, rehab, nutrition, activities. We do transportation for our participants. They come into a center, we can feed them, we can provide personal care to them, and we provide an environment which is really inspiring and gives dignity back to people's lives, and we listen to what they need and what their families need. If you go out and talk to somebody who's caring for an aging loved one who's very vulnerable, and you ask them, what would it take for you to continue to provide support to that loved one so that they can age in place? They'll tell you. I mean, this is not hard for them to come up with what their requirements are. And a lot of it tends to be not about the medical stuff. A lot of it really tends to be around the social vulnerability and the connections and the integration and coordination of care. So we are launching PACE programs. So that is our mission. Our purpose as a company is to unlock the full potential of our most vulnerable members of society. How we're going to accomplish that is to bring PACE programs to as many markets as we possibly can that are currently underserved and do not have PACE programs. So we're launching PACE programs in California. We have one nearing launch in Stockton, California, which is the largest city in California with no PACE or adult day services. Second program launching in Pasadena. Other programs in application in California and also outside the state of California. So that's what PACE does. That's our mission. And PACE can be accomplished in an extremely low-tech way. So I'll dovetail just briefly into the other part of your question. I also have a technology background as the president of Airstrip, which is a digital health company, a pioneer in creating software as a Class 2 medical device on mobile devices. So I have a passion for technology. For us, we view technology first and foremost to solve the very basic workflow challenges of communication and connecting with people. Second, to bring decision support at the moment of decision, at the moment of care. And third, to amass, very valuable longitudinal match data for our participants and actually having our participants gain value back from sharing that with others. A very direct way of allowing individuals to participate in a big data marketplace. So the things that go wrong are the tried and true things. It is not knowing your requirements before you develop a solution. It's very, very simple. So if you get that in the wrong order, you're always going to miss the boat. And I think the other thing that is very, very challenging from an innovation standpoint, a technology standpoint, is I actually, as painful as it is and highly regulated as my world is now, I actually feel really bad for folks who don't have the top of the food chain control of the payment mechanism. This has been mentioned multiple times today, but I'll say it again. If you really don't have the payment mechanism lined up in what you're providing, it is incredibly difficult to change how healthcare is delivered. As a Navy surgeon, I made the same amount of money if I did something to a patient or not, operated them or not. And even in that environment, socialist America I call it, as a Navy brat and a Navy doctor, so I grew up in socialist America. Even in that environment, you still had doctors who just could not wait to find interesting pathology and shoot a laser over their back, across a mirror, across the room, and fix it. That is just how we've trained our medical practitioners to think and behave. And what we really need is an army of very caring and empathetic listeners who are motivated and passionate about behavior change and connection. So that's really the pieces that are missing. If that part gets taken care of, you can layer in technology very, very easily because the requirements will kind of fall right off the page for you.
Right. Well, we also then have two folks who are very involved in the kind of telehealth market. I'm going to go back to the next nursing home step before I come back to Mary. But when you started Call 9, not 911, the idea was kind of a high-tech, high-touch. You would actually physically embed people in nursing homes in case there was an emergency, but you also have like a network. Well, I'll let you explain it because you'll probably do a better job. But
you're doing great.
Okay,
Keep going.
Call 9.
I'm going to get you to start pitching for us. Thank you. And thank you to West and to Rochester for making this, bringing people together to share ideas is incredibly important. So Tim Peck, so the founder of Call 9. What we do is we deliver emergency care to patients in nursing homes. Why would we do that? So patients in nursing homes make up 19% of the ambulances that come to the emergency department across the country. So I'm an emergency physician, and when seeing patients, 1 out of 5 of those ambulances has a nursing home or subacute rehab patient. It's a lot of patients, right? It's a lot of our volume. And then what CMS did is they looked at this population and said, how many of these patients even need to come to the emergency department? How many of these patients need to go through the event of becoming delirious because you've changed their location, getting the poor care or the care that we can supply to these patients in the emergency department? And they said 2/3 of these transfers are actually avoidable. And that makes up a $40 billion unnecessary spend for the payers and Medicare who cover the patients in nursing homes. So I was an emergency doctor. I saw plenty of these patients, but knew nothing about the nursing home. Right? There's a chasm that exists in between the nursing home and the emergency department. And I'm a doctor, and went through medical school and volunteered in the past, and I never stepped foot in the nursing home. So what I did is I went and lived in a nursing home for 3 months to understand as much as I possibly could, and to see what I could learn. And what I learned is that it was an emergency department, right? And that's why they were sending their patients there. Nursing to patient ratios, 1:20 is the best I've ever seen. 1:30, 1:40, 1:50 at night can happen. So one patient gets sick, 19 other patients need to be taken care of for their chronic needs, and that nurse has chronic care understanding, not emergency. So 911, get that patient out. Lab tests are very sparse. EKGs take 24, 48 hours to come back. And then thirdly, doctors are not present in nursing homes 24/7. And overnight, holidays, weekends, when I was walking the halls in this nursing home I was living in, I never once saw another doctor other than myself. So what we did is we created program to kind of combat that. We have a first responder who's an EMT or a paramedic, a nurse with emergency experience, ED tech. What unites all of them is that they understand emergencies. And we take that person, put them in the nursing home 24/7. They go to the bedside whenever there's any type of acute need for the patient. They tap our app on an iPhone, connect to our emergency physicians who are home, remote, 24/7, and able to treat multiple patients in multiple nursing homes at once, like running a remote emergency department. And each of these first responders have a bedside diagnostics with them, EKGs, bedside labs that result within a couple minutes, telemetry, ultrasound, real-time ultrasound, and put in IVs, give fluids, medications, and 80% of the patients we see get to stay in their beds, where 20% go to the emergency department still. We get to save a lot of lives that otherwise wouldn't be saved, which is part of the beautiful part of what we do. Those 80% make up $8 million per 200-bed nursing home per year of savings. So that's where the value comes from for the payers, but there's also value for the patients and the families. And what we've seen in healthcare, I think, and I think many people on this panel would likely agree with this, is that over the last 3-5 years, those who are investing in healthcare technology and healthcare services are starting to understand that value doesn't only mean saving money, but you need to create that savings through good patient care. And value really means both of those things. And through that, you can come up with business models to be compensated. And we do value-based contracting with all the large payers to be able to support this model. And through that, you can create new models, new changes in the way you deliver healthcare so that you don't have to just add technology onto a broken healthcare system, but take it onto yourself to actually change the way the healthcare system is delivered, similar to the PACE program coming in and making radical change there. So that's how Call9 works.
Well, so the whole idea of video telehealth consults is obviously taking on a big, my first introduction to it was when I got that little benefits thing that you get every year, every month with your letter that you don't read from the company that says you can now use, this video doctor service. And when I was talking to Mary before the conference, I said, well, I've never used it, but I don't know who this doctor is, and this isn't. How do I know who they are? And I don't know how. And she said, well, that's the difference with what we do, which is that you are going, as I understand it, your company will contract directly with health systems and get them to begin to embrace telehealth as part of their services for patients. So you might not always see your own doctor, but you will see a doctor that knows where your records are or has some ability to gain knowledge about you. And I think you've given some examples, which I think you can share one or two about how it's worked with specific folks, like in Wisconsin. The urgent care issue was sort of a really interesting one, to be able to show that video consults can work for certain situations and for certain patients, and that there are actually ways to show how that saves money in the healthcare system by using this technology.
Yeah, thanks, Laura. So good afternoon, everybody. My name is Mary Modahl. I'm with American Well. We're a telemedicine software software company here in Boston. I'd also like to thank West Health and University of Rochester for hosting the event. It's an honor to be here with all of you today. And it's exciting to talk about these new technologies. For me, it's really fun to learn about the things that you guys are doing, as well as be able to share a little bit about what we're doing. So at American Well, we are providing telemedicine software to health systems, also health plans, also consumer companies and mobile phone companies. And that software is interconnected in such a way that it allows patients to obtain medical care from anywhere. And it allows medical providers to offer medical care to anywhere where they're licensed to do so. So I think at the core of what we believe as a company is that every clinician will have a mix of face-to-face care with their patients and also remote care with their patients. And not only that, they may need to bring in other providers of care, such as family members. That adult daughter may need to come into a care discussion. I know that my conversations with my own aging mom are like, a weird labyrinth of medications that she can't pronounce, and I'm trying to get her to show me the bottles and stuff. You know, she's in California, it's very difficult. Bringing those folks in, also bringing in other specialty providers or maybe you know, allied care providers that can really help a patient. So at the core of the American Well telemedicine system is the belief that every clinician needs to see their patients both in person and remotely, and that should be actually fairly seamless. So the software system allows you to create, of course, a video visit with a doctor. It allows you to invite third parties in. You can have 8 or 10 people at once in a meeting, so you can have group things or one-on-one. It also integrates with electronic medical record systems. So for example, health systems might say, okay, we'd like to offer an urgent care service, and if a patient comes to us that we don't have a relationship with, we'd like to instantiate a record over there in our electronic medical record system. And if we'd like to ask them during the visit, do you have a primary care doctor? So, you know, going to a couple of the clients' stories here, as an example, the Avira system, which is a system up in the Dakotas, they have 1/3 of the population surrounding their system is what they call undoctored. They have no primary care doctor. So they've used the system to actually create points of care in a grocery store chain called Hy-Vee in the area. And if you go into the Hy-Vee, you can get come in, you can get a visit with a doctor, and they ask you, have you got a primary care doctor? And if you don't, they get you signed up so that you obtain a primary care relationship. So this is one example of a use of the telemedicine system. But hospital systems use these for all different kinds of applications. You mentioned the one in Wisconsin. This is WEA Trust. This happens to be a health plan. So we serve plans as well as systems, as well as consumer companies, pharmaceutical companies, all types of applications for telemedicine. WEA Trust is a health plan, and they serve primarily teachers, firefighters, and other public employees. And most of these folks are on high deductible health plans, so they've got a very high cost of care for their visit. And WEA became very concerned that their members, in fact, would not go to seek care at all, even when they needed it. And so they would let something become worse and worse because, you know, their average income of the member of their plan is actually probably about $40,000. And so they said, you know, we've really got to provide something. And so what they did was they created a telemedicine consult service that's free to members. So if you've got a problem, stop first at telemedicine and see if you really need to go in, and if you do, get in. But if you can take care of it with a home remedy or whatever, here's a service that allows you to do that, you know, for free. I could go on and on with different use cases. I'll share just one more and let our panel continue. One that I'm pretty excited about is a wound care program, right? So another one of our hospitals, this is down in Florida, it's the Bay Care system. They actually they have patients that have wounds, they go home with their wound, and now, you know, they need to follow up for wound care. And so this was a very expensive thing for them before, right? They could either send a specialist or a nurse out to the patient who has the wound in their home, or they can transport that patient. Oftentimes these are burns, right? So they're serious, and you know, this was really expensive. It was difficult for the patient. It was actually painful as well. And so they started a telemedicine program to deal with wound care, to allow patients, once they get home, to have their wounds seen, to have somebody that they regularly consult with, who was the same doctor that they dealt with in the hospital, but now they're going to be following up at home. And so telemedicine is one of those areas that can be difficult to understand because there are so many applications of it. But I think that the big aha of it is that if the software system can interconnect everybody with everybody else, then a world of innovation can be enabled. And we get away from those point technologies that you were referring to, Joe, earlier, where, you know, this does this and that does that. Instead, let's plug into a system that can do many things.
Turning your bedroom into a Best Buy showroom.
Right.
Yeah, exactly.
Well, we were talking earlier, so there's a wonderful video. One of the things that I think is really important as we get all these innovations is getting that aging population to understand that I can get really good care this way. This could actually help me, the adult daughter, you know, if I give this to my mom and I convince her to do it, you know, this could help. And I think you had some interesting data about how few people currently use the kind of technologies that are like, you know, I've fallen and I can't get up, or, you know, pill monitoring and things like that. And I think that was kind of surprising.
Yeah, I mean, we've been monitoring this for a long time. If you think about personal emergency response systems, I hope my phone can't get up, devices, or social alarms in Europe, as we like to call them, and we've been tracking this for years. And of the frail population over age 65, does anyone want to take a guess as to what percentage of that population actually adopts these technologies? under 5 in the United States.
And when they pay for it,
Now let's assume that, frankly, we're too cheap to pay a cable bill for our mother, and that we need the government to pay for the whole thing. So we'll go to the National Health Service in the UK, where they will pay for the whole shot because the doctor said you need this. What does it go up to then? Closer to what the person in the cheap seats mentioned. 12% is what it goes up to. We're designing systems that say something about us, about what we've lost, what we need. We're not designing systems not simply to monitor, manage, and motivate, but we're designing systems that basically have clinically put you, although in your own home, into a hospital room. How can we start thinking about d.health and the related services and the like to be much like a microwave oven? All of us typically have a microwave oven because it's convenient, it's easy to use. It's in your house in your 20s, your 30s, and by the way, it ages with you into your 60s, 70s, and 80s for that 40% of the 70-plus female population that lives by themselves who want to make a quick meal that's semi-nutritious. What I'm suggesting to you is that we need to start looking at innovation as those things that get into our home that are cool and convenient and not necessarily things that we need later on. And it's starting to happen. Just very quickly. The Internet of Things, which I know has kind of been overly discussed and the like, but when you start looking at Samsung, the F economy, where the refrigerator is connected to the toaster and a variety of other things, we are starting to create an envelope of convenience that is transitioning into latter life into an envelope of care. The sharing economy that is, shall we say, spurring the millennial dream of how to live with ease and seamless, have it within 30 seconds or don't have it at all. Those things are now becoming Meals on Wheels virtually delivered. We're now starting to see your wash be able to be done by an outside service. That with the right coordination and the right tools and architecture, an adult daughter or someone who's living by themselves can start to create a virtual PACE program in their home, in their neighborhood. I'm not saying it's the complete answer, but the aging population around the world is far too large, far too diverse in both desire and income to think that any one set of technologies or services are going to do it. We're going to need private, public, public-private, and still, yes, sons and daughters, you're still not off the hook.
right? Well, unfortunately, the other statistic, of course, is that I think something like a fifth of women, many women are living alone, but a fifth of women actually never had children. And I can probably guarantee you stepdaughters aren't going to be the ones that take care of you. But
yeah, I mean, that number actually, the most impressive demographic number came out 2 weeks ago.
Yeah.
I think everyone's just ignoring it because it's too geeky.
Yeah.
We have a record low birth rate in the United States and many other places. So the question now is, can we design technologies not just to alert the adult daughter that you haven't taken your meds? Can we invent a robotic adult daughter?
Right.
Who's going to be that person?
yeah, and then I think obviously the idea that you can expand caregiving through some of these technologies and just through some of these ideas. I mean, for example, monitoring people who are in nursing homes. If you don't have the family there to be looking over your shoulder a lot of times, you have to think about important things like, well, do I know this person well enough to know that they're just not acting like themselves today if there are so few caregivers? I thought one of the things, Matt, that you said that was interesting is even though you said you can deliver this mostly low tech, in the second phase of this, you could look at things like, we're always hearing about artificial intelligence now and all the amazing things. Maybe someday there will be a robot taking care of people. I know they're working on robots that can suture you up after the surgery. But what can things like, we're not supposed to use big data, but data and artificial intelligence, how does that kind of come into this maybe substituting for those family members that either aren't there or living on the other side of the country or...
Yeah, in the earliest phases, advocacy is just such a strong component of what people need in a moment. In the United States, we tend not to want to engage with our own health. There's a lot of talk around that and a lot of failure around that. What we are pretty good at is engaging in a loved one's health, and we're pretty good at engaging when everything goes wrong. So we tend to have a lot of interest when stuff really goes wrong. So there's a moment of opportunity there, and so I think technology in a very early stage can simply be how do you more appropriately listen to somebody in a time of need and allow them to have enough information to ask for what it is that they think that they need. So medicine has become so transactional that as soon as a care provider starts going through the motions of, I'm about to prescribe something for you, I'm about to order an intervention, we kind of just say, okay, this is what I'm supposed to do. This is how the transaction works. And so you just get trained into wanting to do that transaction over and over again. So I think there is still risk that if we introduce a lot of interesting technology or things that people find desirable, there's still the risk that they would use it in a way that's still getting in that misaligned incentives of transactions. So I'm always amazed at the text messages I get from friends of friends who will tell me a horrible thing that's happening right in that moment, and there's doctors all over the place in the hospital, and in five sentences I can read something and respond back with just the right question to ask that changes the trajectory of a hospitalization. And to me, it's like the most simple, obvious thing in the world. For others, it's like I'm a magician, and it's just because you don't have advocacy. You don't have somebody there who knows how to ask the right question, given what's going on right now, that all of a sudden gets the entire care team who's on site to go, okay, now I understand the situation, now I know what you need, now I can help you. So I think technology can play a role in that, in bridging that communication, and it can go all the way up to hospital at home. So hospital at home has been around for a really long time. There are no PACE programs in California doing hospital at home. It's amazing to me. I can't believe it. So for me, coming from medicine as well as a technology background, where you can monitor things that, you're doing this as well. You can monitor things you can only dream of having done before. You can provide such better care in somebody's home at a time of need that is so much better than sending somebody to the hospital. And that can be technology assisted as well. So we're really excited about being able to get greater situational awareness. And that can be very simple, from help me ask the right question. Really, I'm just lonely. I don't need to go to the emergency department. I just need somebody to talk to right now. All the way up to, we're going to treat your CHF exacerbation at home because you'll do better at home than you would have done if we admitted you to the hospital.
Well, and Matt, I want to pick up a little bit on what you said about healthcare being so transactional, because there is something about the going in only to the temple of healthcare, right? We go into the temple and then we receive our transaction there, right? And so, one of the kind of out there, I think, ideas about telehealth and telemedicine is that we can actually rethink how often we interact with people and for how long. In other words, once I go into the temple, I'm in there for like 3-4 hours, right? It's a big experience. Even if I'm in there for something really simple, right? I'm just going to go in, for 45 minutes. If I'm in there for something complex, I could be there for hours. But what if before I have this event and I have this transaction, I actually have much more frequent, smaller interactions with somebody who's caring for me? So, maybe the way we approach chronic disease, maybe the way we approach wellness in the elderly, maybe the way we approach moms that are expecting can really evolve, because now we can have many 8-minute interactions and not one big visit to the temple for 6 hours to go through a big transaction. And maybe we start to think differently about it.
Right. Well, avoiding hospitalization, avoiding emergency rooms obviously not only makes sense for the patient, it makes sense for the healthcare system, which especially with nursing home patients, because you're going to get a lot of intervention and a lot of cost.
Yeah.
So,
and those touch points are so important, and making sure that you're with this patient population who suffers from isolation and loneliness. People often ask me, who are these first responders? Because we kind of came up with this new model where we put someone in the nursing home. Who really are they?
and they have technology with them.
They have
bedside
technology, a lot of technology that is able to treat the patient, but also connect to an emergency physician. And we even have a palliative care program now added on, and connect to those physicians remotely, so that physician can make the medical decisions. The first responder in the field can be the hands. But they're also there for the social determinants of health piece, to put a hand on their shoulder and just be with the patient when something is going wrong. One way I like to describe them and get people to imagine who these people are that we've hired to put in nursing homes is most of them are EMTs and paramedics, and the screening question that we have is we say EMS, Emergency Medical Services. Which of those 3 things do you identify with most?
Yeah.
And when they say emergency, we say, thank you, it's been nice to meet you. There's the room for you to go to, have a good career. And when they say services, off the bat, we ask them to say it right away. What's at the top of your head? When they say services, now you know you have someone who's caring. Now you know how you have someone who you can empower to make a relationship with the patient. And so nursing homes, the national average for a long-term care patient in terms of number of minutes of nursing time per patient per day is 29 minutes. That's what's happening in a nursing home. They have 29 minutes of touch points. So there's a lot of loneliness. If anyone has ever been a patient anywhere, imagine being alone for 23 and a half hours. So what we do is we have that person in there and we change that minutes by 5-6-fold for that patient. And so that's incredibly important to engagement. It's incredibly important for comfort. It's incredibly important for health outcomes.
Are most of the patients in those nursing homes permanently in those nursing homes, or are it's rehab as well?
Yeah, it's subacute rehab as well. So some of them are short-term
So they will
care.
get out and
They'll come. Yep, they'll come after their hip fracture and have a couple weeks of getting over that and go back home. So, or people who live there permanently. Right?
Well, I think the idea of technology that can be adopted easily, going back to this idea that, you're talking about many people in nursing homes now. I'm always amazed when they start saying, at 50, you start to kind of segue into that, what they consider aging, and in the 60s, now you start to get multiple chronic diseases. Oddly, I've had an experience where 5 or 6, actually, of my closest friends are in their mid-60s and healthy as the day is long one day, and the next day are fighting major cancers. So you start to see that these things can happen at any time, and the question really is, can this generation, at that segment, people who are in midlife, who are kind of heading into some of those health crises of the future, we are tech savvy. We do know how to use these things. When I first started as a journalist, I hate to say this, there was no internet, there was no cell phones, there was no computers. I typed on a Royal typewriter on triplicate, and I swear to God, I don't remember how I did my job. Yeah. And how I found out anything or got in touch with anybody. I really have no idea. There was no Google. So I tell young reporters that now, and they look at me like, but I think we are a generation that grew up with technology, and I think we would be prepared to have it help in our lives. You did this great MIT AgeLab video, which we were talking about earlier, and I think it was called Life on Demand. And it's a very cute animated video, which you should look up if you haven't seen it. I think you can find it online. Tell us about it.
It's on YouTube, and it's a fun little cartoon my team put together called Life on Demand, A Possible Life Tomorrow. And it's on YouTube, just Google that and AgeLab. But it's a cartoon showing how the sharing economy and connected devices and the like might create not just a place that provides an envelope of care, but actually provides, shall we say, a cool, convenient lifestyle for older adults. And so it shows the possibilities of how Uber and all these other things could come together for a better life. I wanted to pick up on one thing that Laura was segueing and see if I can push our discussion and all of you to think about. We've been pretty much discussing health basically for a population that, shall we say, proverbially is 1 foot out the door and 1 on a banana peel. I want to push the envelope a little bit, which is, yes, the baby boomers are coming up and more tech savvy, but the technology changes so quickly that every generation gets old very fast and faster, actually, including Generation Z. But can we push the definition of d.health to be about well-being? I grew up in Philadelphia. I still believe that cheesesteaks and tasty cakes and Scrapple are food groups. At some point, I probably need either technology to guide wellness behaviors so that I don't see you guys quite as soon as I might otherwise. And so rather than creating a safety net, why don't we invent a lifestyle around, and I don't know if it's wellness or well-being or whatever, those words are getting really tired and old, but something that's about being proactive healthcare rather than reactive healthcare. And I think that we've got the possibility of creating services, technologies, and social networks to make that happen.
Yeah, I think that's great. And I think it's a checkpoint for people who are looking to innovate in that space that you're describing. And the things beyond health, and it's not necessarily unique to the aging population, it's really autonomy and independence. This is what people really are striving for in their life. They want to call their own shots. They want independence. They want to be autonomous. They really don't want a safety net and have to fall under custodial care, most people. And that's true even, to a young person who has a sports injury that, has a broken leg and can no longer snowboard. I mean, that's sometimes the first striking example of a loss of independence. And I think that there's a consciousness around that. So I think it's a great checkpoint for folks on the product teams, for anybody, service provider, technology, really anybody, to just check in on are the things that we're doing lending themselves to helping people be independent and helping people be autonomous. And that is well beyond health, right? So that's why my mom using a ride-sharing application is so wonderful. I mean, it just really gave her a sense of independence and autonomy that she didn't have to rely on somebody else's time to come, and she didn't have to wait for somebody to take her to an appointment. She suddenly had this ability to go where she needed to go on demand. This is a wonderful thing. Same thing with any food services or entertainment or all of those things. I think that's highly relevant. I think the more that people can engage with those things in their life that bring them joy and give them pleasure, the more likely they'll be able to use the same types of tools in times of duress, in times of need. And I think it's very much aligned with where you were saying initially.
Live 24 hours alone in their own home. What you said about nursing, that's terrifying. Yeah. But a lot of us are that way at home.
Yeah.
Well, I think there's also the question, though, that you can't, the obvious problem with America and its population, with all the best intentions, you have, such a high level. You have, 90 million obese. You've got people with so many multiple chronic conditions. They're fighting heart disease and diabetes. Well, we all know the numbers. We've seen that. And I guess the question is, is there a way to have you seen anything out there that kind of addresses those lifestyle changes that need to be made? I mean, I know people have Fitbits. One of the problems that has been talked about with digital health is you've got all these consumer apps that are, people buy, they put them on their wrists, and then they forget about them, or they just focus on how many steps they can take until they fall down with exhaustion. But what about the ones that could, connect you back? More of the ones, when I'm looking in my reporting at the digital, healthcare field and all of these new apps that are out there, the ones that I find interesting are the ones that connect you where that information is going into a medical record. It's somebody's looking at it, or even if someone's not looking at it, there's an algorithm that kind of clicks up what it says, this person hasn't done something that they were supposed to do, or maybe they're wearables, maybe not wearing, maybe there are other ways to do it, but what's out there that can help us in that path to having more well-being, because we are living longer, but we're living with worse health.
I think one of the interesting things, so we've had the great honor of being included in the Apple Health study, the Apple Heart study. And this is some research that's being done by Stanford University on the watch. So the watch is, people wear their watch, they see if they have, the watch actually monitors their heart rate, and it detects patterns that suggest that the person may have AFib. And what's so interesting about it is that this is a mass scale trial, of a consumer device, where people didn't buy the watch because they said, hey, I think I might have AFib, I'm gonna buy the watch. They said, I'm gonna buy the watch because the watch is kind of cool and it looks cool, and we were discussing it last night, Laura and I are not watch buyers, but but many do, I see you yourself. And so, many people buy it because they think it's fun, and then they realize, oh wow, this thing can actually let me know if I have a problem. What's kind of cool about that is that when that watch detects a problem, of course an alert goes, the patient can connect immediately with a doctor. The data goes from the device into the telehealth system. The doctor comes in, there's a screen that the doctor's looking at and sees the entire pattern of the heart beat there. And then, this is a clinical trial, so obviously, some of them are gonna be, need intervention, some of them are gonna be false alarms, et cetera. But the ability for somebody to find out that they have a health problem from a device that they bought for a completely different reason, just for fun, right? Because they wanted to have their cool stuff on their watch. That's really a shift, I think, in the way that technology is used.
Yeah, that could be a step in the direction of, here's kind of my blow it all up statement. Is it all just dopamine? Is that the problem? Are we actually contributing to the problem by creating things that are just activating a brain pathway which is bad for you. And all of this behavior is leading to chronic disease. We're just creating a need for things that we're trying to fix later on, and ultimately just goes back to dopamine. That's it. So, I mean, what's the real innovation? The real innovation would be invent things which are dopaminergic, which are good for you. Transcendental meditation. Invent an app that does that for you.
I think they have one.
Yeah.
I just-
So I mean, perhaps that's really what this is all about, and we're missing this broader point that ultimately there's just a very, very high-powered reward system in our primitive brains that just sends us down the wrong path, and it's too easy to fall into that, and we have to kind of hijack that somehow.
And for all the developers out there, I mean, take a page. I think we're being profoundly too rational about healthcare. The dopamine thing is, it makes you smile, but we know what changes behavior, and yet we spend billions in research dollars, which is okay, I like that. Spend billions in research dollars. How do we get people to change their behavior? Have you ever been to a shopping mall? Friends, fashion, and fun.
Sale.
Right now, but having something say, Joe, your blood pressure's up. Not exactly cool.
Yeah,
But now
totally.
if you can say social network, friends reinforcing, that gets people's behavior. And you know something? Older folks are all of us. They like peers. They like social pressure. They like interaction as well to say what you're eating, taking your meds, and oh, by the way, can you pass me that fudge cookie recipe that you had? I mean, little things like that. And so not just one device at a time, but we have to invent a lifestyle that's healthy, not just monitor your blood pressure.
So one of the, I think we have to open it to questions shortly, but one of the other things I wanted to ask is I've been trying to understand how regulation and how the federal government and the kind of the barriers, obviously reimbursement is something that everybody's working on trying to figure that out. But I was fascinated that there's this now, FDA now has this, software as a medical device, which they're trying to sort of give you an FDA approval. Now, someone had mentioned that they've already got one of those.
Yeah,
okay, right, that was you. Okay, so that you actually can say, someone has looked at that enough to suggest that it can be that this isn't just a scam, and the FDA has approved it. I guess it could still be a scam, but how do things like that help in the design? I mean, does the FDA belong in this, or can the FDA? I don't know that they've regulated anything else so well, but can they? Does government belong in this? Is this a
Me?
You've got your
You're the one with the FDA-approved device,
Be
right?
careful what I say. So, it was
turn on the
wonderful working with
recorder.
the FDA. We actually did have a very good collaboration with them early on, and I think one of the opportunities you have when you innovate is you get to educate your regulator. They really, deep down inside do want to do the right thing. I think where it's getting increasingly, for us, it was a very, bona fide medical use. People in a hospital, an obstetrician looking at a waveform pattern of a woman in labor in real time. I mean, it was a lot of safeguards around that. I think where the controversy is, I actually went to Congress and testified in the House around the FDA's role as it related to consumer applications. And believe it or not, the one app that really had the most common sense kind of ringing the bell was a dermatology app. That's where it kind of crossed the line for the representatives on the panel, where they felt, okay, it's all well and good if you're just kind of getting guidance and you're getting advice, or you're quickly engaging on some health issue. But once you start sending a picture of a skin lesion and somebody's telling you that's cancer or not cancer, that's where we need to get involved and make sure you're doing the right thing. But overwhelmingly, the position of the FDA at that time, and it's evolved since then, was you guys need to figure this out, because if you don't, we're going to figure it out for you, and I guarantee you're not going to like our version of it. So I think that the answer is look to ourselves. What are we going to do to put in safeguards and common sense things on quality control and peer review, and that will avoid the situation of having ambiguous overregulation.
and the reimbursement issue?
Yeah.
I don't know if that's.
Yeah, I spend a lot of time in Washington, D.C. I've spoken to over 100 congresspeople and senators in the past 6 months, which has been actually pleasurable.
I was going to say, is that what sent you to the nursing home?
That's right, yeah. That's exactly right. So, but these conversations, the thread here that I get in these conversations is Our job is not to innovate. That's what they literally say. Our job as the government, our job is not to innovate. Our job is to partner with you and to enable you, the business, to innovate and society to innovate and to clear up those channels. And then they say, but what we need is data. Every single one of them. But what we need is data. Show me that it works. Show me that it works. And that's where I think we have a West Health, we have a University of Rochester, and academia, and business, and not-for-profits, and policy shop kind of coming together to say, let's study things. Let's understand what the efficacy is, both to cost and to value, so that we can hand that over to government. CMS asks for it, CMMI asks for it, Congress asks for it, and partner with them so that they can help us do the work. Okay.
I think one of the most interesting things about reimbursement actually in telehealth is that it has taken off in commercial first. Very few things do that, right? I mean, almost everything gets approved by Medicare, Centers for Medicare, Medicaid Services, and then that becomes covered, and then the commercial guys drag their feet finally, okay, finally we're covering it as well in our programs. The commercial guys have all taken a look at telemedicine and they said, you know what, this is a good idea, and they've done their own studies with their own claims, and they said, you know what, we're saving a lot of money. I mean, Anthem published a study done by Health Corps. I think it was $202 a visit for their telehealth. Intermountain hasn't yet published theirs, but they presented it, the American Telemedicine Association. They found, I think it was 320 or something for commercial populations, and they looked at a Medicaid population, and it was like 720. It was a huge savings to avoid, and that's not even counting the convenience for the patient.
Right.
So you see commercial moving very quickly with telehealth, and you actually see Medicare much more slowly moving.
Yeah.
They're afraid that it's so convenient and fun that people will start to do a lot more visits. And the commercial guys were afraid of that too, but that's not what they're actually finding. Right? So it'll be interesting to see how it plays out. A lot of consumers actually will pay for it out of their own pocket because, you know, they're
convenience. And
they're on a high deductible plan anyway. They're going to have to pay the first dollar anyway, up to $2,000. So they think, okay, well here this thing's, you know, much more convenient and maybe not more expensive, or you know, less cost. And then there's some people who are insured in the doctor's office, but it's so much more convenient. They'll just pay cash for the convenience, right? You're traveling business
PayPal.
person, right, or something. We'll say, okay, I'm on a business trip. I've got a problem. I'm just going to pay cash. I need to take care of this thing.
well, I think we have to open it up to questions.
This is for Tim. I just want to get a little bit more clear on how Caughlin works.
Sure.
Does the SNF pay for the person you send in there? And is that person considered an employee or a consultant?
Yeah, that person is an employee of Caughlin.
Of Caughlin, not
right.
the SNF.
So
Okay.
we're a medical practice, and they're part of that medical practice, an employee of ours. The SNF pays us a fee to be there and to give some services. That covers some of the cost. And then the other parts of the cost and profit come from the insurance companies themselves, who we charge fee for service until they come in and do a value-based deal with us, and we share in the savings with them. And that's how the revenue works.
And you convince the SNF to engage with you because you promised that you're going to save 2/3 of the...
Yeah, so there's two different value props here. There's one for the payers, which is more obvious. We're saving money, we're giving them data on what's going on in the nursing homes and with their patients that they might not be able to see and treat. So that's one that's more obvious and where we get our shared savings from. For the nursing homes, there's a huge value prop here, both financially, as well as for their brand, as well as for their patients. I'd said that there's no 24/7 presence in nursing homes in terms of physicians. There's a small amount of very wealthy nursing homes that have that, but for the overwhelming majority, they're not. Now you have a 24/7 presence. I had said that there's 29 minutes of time for a nurse to see the patient. Now you have another presence there that's doing well visits as well as sick visits on these patients. Changes the quality, the milieu, the attitude of that nursing home for the patient. On the financial side, they have 5-star ratings. You know, everybody has 5-star ratings now. And nursing homes have 5-star ratings, and they're driven and get penalized when they have excess transfers to the hospital, excess admissions, and so that helps there. Plus, keeping patients in their bed there with the nursing homes helps them retain their clientele, keep the beds full.
Thanks.
Mm-hmm.
Anybody else?
The basic economics of marketplace requires two things: that the buyers knows the price, which we don't always know in healthcare, but they also know the quality of the product they're going to get, which do not know as well. So how do you really see the definition, not necessarily in your businesses, but at large, of how do we know, besides the star ranking of nursing home, which we know everybody would like to avoid them, even the 10-star, which does exist, okay? So what do you see is the future of using data? If I want to find a cardiologist, or oncologist, or psychiatrist, how do you know quality? Because it's pretty much opaque for most of the individual, for me, for my beloved ones, etc. So do you see any change there, or it's going to be secret as far as I can see? What's your view on that?
I mean, the only really easy data is patient feedback, right? So what was the patient's experience? But the patient's experience is very subjective, right? It's not a medical experience that a doctor might say, well, that's a lousy doctor, but a patient might say, well, I think he's fantastic because the bedside manner was so great. My father is fond of saying that the grumpier and more unpleasant the doctor is, the more confident he feels in the care, because this must be a good doctor, because in order to have any patients, he must have to be a good doctor. So, everybody interprets the data as they will. But those are the only really easy data. I mean, correct me if I'm wrong, those of you who are MDs, but I think even among physicians, there's quite a bit of debate about what constitutes good medical care for different conditions. I mean, there are certain care pathways that are reasonably well defined, and if X, then do Y. Mm-hmm. But a lot of care pathways just don't seem to be that well defined, and what constitutes good care for patient A maybe doesn't constitute good care for patient B.
Right, and there's also a lot of resistance to any kind of physician individual rating, although I just saw a presentation from Yelp in which they're trying to do that, so. Yeah,
I'm having a Zen in the art of motorcycle maintenance moment. How do you define quality? It drives you insane. But the only thing I would layer on to what Mary had mentioned would just be probably the most important intervention that we can make in society at large in making medical decisions is for them to understand the concept of aligned incentives. So that's what's really, really missing right now, is that most people don't know the questions to ask to understand whether or not somebody is truly looking out for your best interest. That's really missing. That's fundamentally missing. And so it's simple. It's a simple way to educate people to just inquire when they're about to get a service or they're about to get an opinion from a doctor or any kind of healthcare service. How do you make money? How do you benefit? Under what circumstances do you benefit, and is that aligned with the thing that I'm looking for?
Did you invent this device?
Yeah, that's an essential piece of quality that you have to understand. Am I going to get the thing that's really aligned with my best interests? And if I don't know how you make money, or whether or not you make more money taking me to the operating room versus not, then I'm not informed enough in my decision making.
Now that, I think, is still one of the biggest barriers for patients to get information. A lot of us basically use recommendations from friends, and I try to get my people in to see the doctors I know are good. But there are hospital ratings like Hospital Compare. People don't use them. So maybe it's a matter of getting the information out there and making it easily understandable and accessible.
But even the measures are not necessarily reliable.
That's
and
true.
Also, some of the best hospitals in the world have the worst ratings because the hardest patients end up showing up at their doorstep.
Yes.
And so that kind of skews what the results are.
And then you worry that they're not going to take the most advanced patients in heart surgery because they don't want to skew their ratings on that website.
I think the CAS lights in the Blue Books are in the right direction. It's the right spirit, but it's extremely imperfect. And they would be the first to tell you of how challenging it is, but I think that is in the right direction.
Joe. So the topic here is about the marketplace to transform care delivery. And I love what you said before about not medicalizing aging and whatnot. A couple of data points: most people want to stay in their homes, their communities, connected to friends, neighbors, etc. And at the same time, when you look at the, quote, innovation that's happening in the aging space, a lot of it are standalone point solutions being sold to the adult child with a value proposition of reducing their guilt. And then you go to my mom on the Upper West Side and you say, Jody bought this for you. We can monitor you now 24/7, and he's going to have just incredible peace of mind as a result. And you know, my mother, good Jewish girl from the Bronx, she's going to give you 2 middle fingers and kick you out of the house and say, "What have you done for me lately?" And so it gets back to this question of, well, what is finally going to lead to consumer adoption of some of these technologies and technology-enabled services? Because, but at the same time, I work with startups. It's really hard to build a consumer brand and to generate the revenue that's gonna, with your burn rate, that you're not gonna burn out before you gain that market traction. The question is, tie all that together, and is there anything out there that you're excited about?
Well, I'll answer that last question in a second. Actually, if I saw more startups that were going after the guilty son or daughter, I'd feel better. That's at least a step in the right direction.
And they don't have to know it's there.
Yeah, exactly. But your story of your mom gave the answer. What did you do for me lately? I mean, in fairness, our discussion in research at this conference and in all the products that are out there is about helping the doctor help do their job better to help you. So it's really about the doctor-you relationship, or the scenario of reduce the guilt of the adult child. No one is inventing a lifestyle here, and I did not pay Jody $20 to give me a step off for my book. But the comment I make in the book is that, frankly, we have not defined the older adult as a consumer. We've not chosen to excite and delight your mother. So until we do, building a brand is easy if you're building something that she wants. So building a brand that's just going to help you talk to your doctor better or to make your daughter feel better, I'm not going to buy that so much.
But I think you're starting to see real consumer companies get into this, right? So Amazon, right? Starts to look at this and says, what can we do here?
And
And they've turned their back on caregiving.
We're in the
Just to be clear.
So the one exciting thing I see, and it came out June, I don't know where it is now, is Best Buy talking about coming out and doing, shall we say, Geek Squad specifically for your mother. Look, I'm not saying that's the answer, but the day we mainstream aging and caregiving as a market and not as a compensation or reimbursement marketplace, that's where you'll have a whole crash of new players from the Amazons and the like to say, oh, there's something here to play. It's not an FDA-regulated activity.
Yes, I think we're in the red and we have to get the hook now. So anyway, thank you very much. Great panel. I really learned a lot myself. Thank you, folks. And we can.
By the way, we should thank Ray and U of R and West Health. This is a truly important and agenda-setting event that's been going on for years. Thank you, guys.
He said.